Good afternoon. Today we will start acid-base balance. First, you have to understand each patient case to read the ABG. So, what are the causes of metabolic acidosis? The most common cause of acid-base imbalance. This is due to gain in acids or loss of base. So, it is gain of acid or loss of the base. Okay, so the H will increase and HCO3 will decrease. This is called metabolic acidosis. When you are in metabolic acidosis, direct respiratory compensation will happen. How? By hyperventilation, compensatory hyperventilation. Okay, like this. When I am in metabolic acidosis, I will do like this, trying to wash out the CO2. Okay, trying to wash out the CO2. So the cause is gain in H as fixed acid or loss of HCO3 via gastrointestinal tract or the kidney. So you will have low pH and HCO3. Both these values will decrease, okay? pH and HCO3 will decrease. And the PaCO2 will be washed, so you will have this fallen PaCO2, okay? What are the causes of metabolic acidosis? We have mud biles and the hard up. Mud biles means HAGMA, high anion gap metabolic acidosis. Mud biles. Any acids introduced will be increasing the anions, okay, because it is negatively charged acids like methanol, uremia in kidney failure, uric acid, I mean, diabetic ketoacidosis, paraldehyde toxicity, iron isonucleotide toxicity, lactic acidosis, ethylene glycol, and ethanol ketoacidosis. Salicylates, starvation, ketoacidosis, and sepsis. All of that called mud biles. This is the mnemonics, okay? And for methanol, uremia, diabetic ketoacidosis, paraldehydes, isoniazide lactic acidosis, ethylene glycol, and ethanol ketoacidosis, salicylates, starvation, sepsis. These three S's, okay? So this is mud biles. So high anion gap metabolic acidosis, this ones, ethanol, uremia, diabetic ketoacidosis, lactic acidosis, and all of that. So this is called HAGMA or high anion gap metabolic acidosis. So this is metabolic acidosis. These ones are called hard ups, okay? Non-elevated or normal NAGMA or normal anion gap metabolic acidosis, okay? We have hypercholeremia, we have acetazolamide, we have RTA, renal tubular acidosis, we have diarrhea, we have ureteral diversion like ureterostomy, okay, pancreatic fistula or sigmoidoscopy, okay, sigmoidostomy. So hard hypercholeremia due to TPN, acetazolamide use, okay, renal tubular acidosis, diarrhea, and ureteral diversion and pancreatic fistulas. All of this, we lose bicarb, okay? We increase the HCl. All of that will cause normal anion gap because will never affect like this acids increase the acids. So keep this in mind. Mud piles and high anion gap and this normal anion gap metabolic acidosis. You have to keep all of this in your mind, okay? We have metabolic alkalosis, but I will go to the anion gap before this. Okay, I will show you the anion gap. What is anion gap? We have balance between the cations, positively charged cations, okay, and the anions. We have a balance. So this equals this. But we have in this balance some difference in the anions, okay? So because there are some unmeasured anions, this is the anion gap, which equals Na sodium alone. This is the positively charged cations minus the anions. So this is called anion gap. When we have high anion gap metabolic acidosis due to mud piles like sepsis, salicylate, starvation ketoacidosis, all of that will increase the anions, okay? So the anion gap will increase. So any one decrease this HCO3 will increase the anion gap, okay? So the anion gap will increase in this. We have some known question. Why anion gap is calculated with or without potassium? Okay, where is potassium? No potassium. Okay, so the reference interval or normal range for anion gap is 10 to 20 millimole per liter. Okay, why this range? Because if it's less than 10, it will be abnormal, and more than 20 will be abnormal. What is the difference between this and this? This is correct and this is correct. We have some anion gaps equation with potassium and without potassium because it is minimally affect the extracellular fluid cations. Okay, it's very easy, and I will show you many scenarios at the end of this lecture. Okay, so don't forget that this is high anion gap metabolic acidosis, and this is normal anion gap metabolic acidosis. We have metabolic alkalosis. What is the causes of metabolic acidosis? Loss of acid or gain of the base. So you lost acid or gain the base. So you will have high pH because of low acids or high bases. A compensatory rise in PaCO2 is expected by hypoventilation, trying to reserve acids to maintain the electrochemical neutrality. Okay, like any cause of loss of HCl, like vomiting, gastric aspiration, and gastric suctioning. Also in what's called gastric outlet obstruction, or what is called congenital hypertrophic pyloric stenosis. So SHIPS or gastric outlet obstruction, you will lose by vomiting, repeated vomiting, you will lose the acids. So acids lost, so it is alkalosis, not acidosis, metabolic cause. Loop and thiazide diuretics, Bartter and Gitelman syndrome and Liddle syndromes. I will show you how to differentiate between these syndromes. Hypokalemia, any cause of hypokalemia, you will have intracellular shift of hydrogen to the cells. So in the blood will decrease, causing metabolic alkalosis. So it is called hypokalemic metalkalosis. Hypokalemic metabolic alkalosis. Primary aldosteronism, which is called Conn's syndrome. Loss of bicarbonate-free fluid, and this is called contraction alkalosis. So the cause of this metabolic alkalosis, loss of H or gain of HCO3. Okay. Okay. Respiratory acidosis, very easy one. The lung cannot eliminate the acid. So the acid, which is CO2, will be accumulating. Again, the lungs, because it is respiratory, so the lungs are the cause. Acidosis, so accumulation of acids, this or this. So the CO2 retained by any cause of hypoventilation. Any cause of hypoventilation, you will retain CO2 in your body. Like what? Like respiratory center depression in anesthesia and morphine use. Very clear that morphine and anesthesia will cause respiratory center depression, hypoventilation, retention of CO2, then you are now in respiratory acidosis. Pulmonary edema and cardiac arrest. Also, cardiopulmonary arrest and pulmonary edema will affect the elimination of CO2. Airway obstruction, muscle relaxants, obstructive sleep apnea, COPD, neuromuscular defect like scoliosis and muscular dystrophy. All of that will affect the lung volume and the lung expansion, like kyphoscoliotic patient, like any cause of muscular disease like muscular dystrophy, you cannot make expiration of the CO2. So the CO2 is retained by mechanical affection of the lung expansion or respiratory center depression or obstructive disease like COPD and obesity hypoventilation syndrome. So any cause will affect the lung expansion or respiratory center. Okay, will affect the ventilation, then the cause is retention of CO2, PaCO2 will high, and the result will be pH high because of acidosis, and respiratory because the cause of acidosis is PaCO2. And after 2 to 3 days, you will find compensatory, partial compensation by gaining the base by the kidney, because we have lung and kidney, metabolic and respiratory. When you have respiratory element, the kidney will be affected and trying to compensate. But the kidney, when you have a problem in kidney, you will have immediate affection of the respiration. So the lung is immediate, but the renal compensation is not immediate. Take 48 hours at least. Respiratory alkalosis. Again, respiratory. So any cause of hyperventilation will make excess CO2 wash. Again, any cause of hyperventilation, you will lose CO2 by so the CO2 will decrease, causing respiratory alkalosis because of loss of acid. Like anxious patient, feverish patient, hypothermic patient. Why? In anxiety, I am doing like this. I'm agitated, I'm anxious. In fever will cause tachypnea. Hypothermia also will cause tachypnea. So the CO2 wash will be high, the pH will increase because it is alkalosis. Here is the it is acidosis, the pH will decrease. Okay, pneumothorax, and don't forget what is called pulmonary embolism. Why? Pulmonary embolism will make very severe tachypnea, severe tachypnea. So the pulmonary trunk is occluded by an embolus. So the patient will be in tachypnea, trying to compensate for this. Washing out the CO2, the result will be respiratory loss of acid, alkalosis. Very nice. So pneumothorax or pulmonary embolism. Hypotension and high altitude, pregnancy, and any cause that cause hyperventilation. Okay. We have a mnemonic here. Rome. Okay. Respiratory opposite, but metabolic equal. Respiratory means CO2. Opposite means one high and one low. So respiratory opposite, when CO2 is down, so the pH will be up. Okay, very nice. So it is respiratory alkalosis. When the pH is down, and this is a respiratory cause, so the PaCO2 will be up, so it is respiratory acidosis. How? You will find pH low and PaCO2 high, so it is respiratory cause. Opposite, the pH is down, so it is acidosis. Very nice. Metabolic equal. But I don't believe in this mnemonics, because if you understood the situation of the patient, you don't need even to read the acid-base balance scenario. Metabolic equal. When the pH is high, the HCO3, because it is metabolic, so the HCO3, not respiratory like the gas is the cause. No, it is metabolic. The PaCO2, sorry, the pH is high and the HCO3 is high. The cause is alkalosis. pH is down. This is acidosis. HCO3 also is down, so equal together. So it is metabolic, because it is equal together. This is down and this is down. So this is metabolic acidosis. I don't believe in this, and if you don't understand, I will show for you again. Normal arterial or normal ABG values. Keep this in your mind. Oh no, they will never give this in the exam. They will give you, but keep for your knowledge. I now read any ABG in any hospital, because you have to be excellent surgeon. pH, this number, 735 to 7.45. The same number of the sodium, 135 and 145 range of sodium. The same number in millimeter mercury for CO2, which is 35 to 45 millimeter mercury, or 4.5 to 6 kilopascal. 4.5 to 6 kilopascal. This is the PaCO2. Keep this. PaO2, 11 to 14. Some people wrote it is 13, it's 14. No problem. It is 11 or 70 to 100 millimeter mercury. When I say the patient in respiratory failure, I will talk in this when you have less than 8 kilopascal. So respiratory failure, it is from 11. Below 11, it is not respiratory failure. Respiratory failure means less than 8 kilopascal the PaO2. This is the definition of respiratory failure. And I will give you very nice examples of respiratory failure type 1 and type 2. Saturation of oxygen percentage from 94, 93 to 100%. Okay. HCO3, 22 to 28 or 26. Keep this values. Okay, please keep this with me. The steps. Know, the first step is to know how is the patient. What is the patient condition? the patient is drowsy, the patient is tachypnic, the patient is septic and feverish, the patient is anxious. What is the condition of the patient? Then you don't need even to read the pH value. Then, is the patient hypoxemic? Because this is first, don't go to pH. Ask yourself, what is the values of sodium, potassium, PaO2? Why? Because hypokalemia is fatal, hyperkalemia is fatal, hyponatremia is also fatal, hypernatremia is also fatal. So O and K, don't miss O and K. Oxygen, PaO2 and its saturation. PaO2 should be 10 to 14 or 30 kilopascal. Below 8 kilopascal, it is respiratory failure. So it is respiration. O. N sodium 135 to 145 millimole per liter. Sodium, potassium 3.5 to 5 millimole per liter. Chloride from 95 to 105. So you have to keep these values first before rushing to read the pH. pH from 735 to 744. Below this, it is acidosis. Above, it is alkalosis. Then PaCO2. What is the cause? Is it respiratory and the PaCO2 is disturbed, or it is metabolic, the HCO3 disturbed? So go to the bicarbonate after PaCO2 and base excess. What is base excess? Okay, you have a line drawn here called the base excess line. Okay. Wait, please, I will. Okay, let's continue. Okay, so you have to check how is the patient state, then oxygen saturation, PaO2, then sodium, then potassium and chloride. Then go for pH, PaCO2, then bicarbonate and base excess. What is base excess? This a drawn line like this, and this is 0 base excess, and from here -2 to +2. This is the normal range of base excess, -2 to +2. If less than this, this is called acidosis because the bicarbonate is deficient. If more than +2, this is called alkalosis because the base bicarbonate is high. Okay. I have an example, and don't worry, everything will be clear in 1 hour. Don't worry. Okay. I will open the mic for Dr. Anyone want to participate with us? I open the mic for him. Okay, Dr. Sami Siyufi. Very nice. Come on, Dr. Sami. Dr. Hisham.
Yes, doctor.
Yeah, Dr. Hisham, you can read this question, please.
Okay. A patient had arterial blood gas sample taken, and the following result is obtained. pH 7.48, partial oxygen 10.1, P-carb 30, partial CO2 4.5, chloride 10. What the most likely cause?
Okay, let's first give the pH values again.
The normal value or what?
Yeah.
Okay, normal value for pH is from 7.35 to 7.45. B carb from 22 to 28, and partial. Okay, I will answer this question. Partial pH is high. That means acidosis. Okay, B carb high also acidosis also, and partial oxygen with the normal. This patient have metabolic acidosis.
Okay. استنى الأذان طالما فتحت لك وأذان شوف. اوكي. الأول حضرتك Okay, so anyone with noisy background, don't request me to open for you. Dr. Muhammad Ashur. Dr. Muhammad?
Yes.
Yes, yes.
Yes, Mahmoud.
Yes, Dr. Mahmoud. Okay. Go on, Dr.
Which of the blood gas result listed below is most likely fit with a patient who has acute respiratory acidosis? Okay, first acidosis, pH must be below 7.35, which will be number 2 or 3 or 4, and respiratory acidosis, there would be retained PCO2. So the PCO2 will be higher than normal. PCO2 10.2. What's the normal range of PCO2 again?
.5
Yes.
لا 4.5 ل 6 sorry 4.5 ل 6. This is the normal.
4.5 ل 6. Okay.
Yes. Or this is in kilopascal, or 35 to 45 millimole millimeter mercury. Okay. So this is 4.5 ل 6.
It's high in the second and third option, so the fifth one is out.
So this
choice.
is not, yes, and this is not,
Yes,
and this is not. So look at base excess. Look at base excess and bicarbonate. Which one is normal? Because this is respiratory, no metabolic element.
The second one, I think it's
Yes,
normal.
the second
yes?
one. Yes, the second one. Again, one by one. First, the pH. Okay. يا رب.
Okay.
Okay, thank you, Dr. Mahmoud. So pH 7.35 to 7.45. Again, PaCO2 will be given 4.5 to 6 kilopascal. PaO2 will be given 10 to 14 or 11 to 13, whatever, kilopascal. Saturation of oxygen will be from 93 to 100% percentage of saturation. Okay, here you have to exclude the wrong answers. This is acute, so no compensation. And this is respiratory, so the CO2, the gas respiration. So the gas is the cause. Acidosis, the pH is above this range. So this one is wrong. This one, I think this is acidosis. So it must be the pH is low. Okay, so it should be lower than this. So you will have this one or this one or the last one. Okay, this is alkalosis, so it is wrong. Also, this is normal one, so it also will be wrong. So it is respiratory, no metabolic. So there is excess, and bicarbonate should be normal like this. Okay. Next one. Because what about compensation before we forget? Compensation, we have partially compensated and fully compensated. Okay, partially compensated and fully compensated. Fully compensated means you have normal pH, which is fully compensated normal pH. This is fully compensation. So you have normal pH. But the values of PA, CO2, and HCO3 are changed. Okay? If you have respiratory acidosis, will be compensated by metabolic alkalosis. So the respiratory acidosis means PaCO2 is high, and also this is very high. The base tried to make the pH normal. This is called fully compensation. Okay, what is partially compensated means that the pH is near normal but not normal, and the two values of PaCO2 and HCO3 are changing, one trying to compensate for the other one. Okay, I will give this an example because I like to give examples, will make the picture more than clear. I will open the mic for Dr. Uday. Dr. Uday,
Yeah, hi.
hi.
Yeah. The question is, which of the conditions listed below is most likely to account for the following arterial blood clots results? Yeah, and we'll go step by step. We'll see the patient. How is the patient?
Yeah, number one, no patient. Very
Yeah.
nice. Number two,
Yeah.
PaO2 is low, but it is not less than 8. So it is
Just
not
above 8.
respiratory failure. Yeah, it is not respiratory failure.
Then we look for the values of sodium, potassium, and chloride. So chloride values are given. It's 12 milliequivalent. So it is between 95 and 105, you said. And I think they are increased here, the chlorides.
Okay.
Yeah. Then we look for the patient's pH. pH is above 7.45, so it is alkalosis. And PCO2, I think PCO2 is less carbon dioxide. So it is, and the bicarbs are 22 to 22, so they are also less. So it is looking like a alkalosis.
So
Mixed
the
alkalosis.
first question, it is alkalosis from the high pH. Then
Yes.
PaCO2 and bicarbonate. PaCO2, is that normal? The normal is
less.
Okay, it is low. So you have a cause of alkalosis, which is loss of CO2. So it is respiratory alkalosis. So it is respiratory loss of PaCO2 by hyperventilation makes the patient in a state of alkalosis because loss of the acid, which is CO2. Bicarbonate, is that normal? Yes.
Yeah, 22 to 26.
So the answer is respiratory
alkalosis.
Okay, the answer is correct. Okay, next one. Thank you, Dr. Uday. You are excellent.
Welcome. Thank you.
Dr. iPad, Dr. iPad von Mustafa.
Yes.
Okay. Read the following question, please. This is very hard. Take care. Okay, it's very difficult. Okay, go on, doctor. Doctor. Okay, Dr. Hassan Zarouk. Dr. Hassan
Hello,
Zarouk.
Salam.
Okay, Dr. Hassan Zarouk, go on.
Okay. The question said that which of the following blood gases result would fit with metabolic acidosis with the compensated respiratory alkalosis?
Leave the compensation now. We can search
Okay.
for metabolic acidosis. So
Okay.
you can exclude now which is alkalosis.
Yes, we exclude C. And this is the one to be excluded now. It's C, alkalotic. Then we have
this
to
one only because
yes.
asked about compensatory, said partial
Exactly.
or fully. Okay, so leave the question now. Metabolic.
Okay.
So
Okay.
where is metabolic loss of the acid? Metabolic loss of the acid. So how to search about this?
The because of this case, we have to check for the bicarb.
This is hypercarbonate, so it is not metabolic acidosis. Then bicarbonate here.
It's 14. This is accepted.
Maybe.
B. Yeah, maybe. Okay, and D also. Slow.
Yes, maybe.
E is the bicarb is normal there. So it should be excluded.
Yeah, this is one is also wrong. Okay, we have now this one may be correct and this one.
Yeah.
Now
then we have to
respiratory compensation. Alkalosis means why by alkalosis? Wash of
wash
CO2.
off out of CO2.
Very nice.
CO2
Is
should
that
be low.
normal or this?
In this one, 7.4, it is high, and in E, it is low. In in D, it's low. So it should be low in D.
Yes, because the normal is 4.5 to 6 kilopascal. So this is washed. So the answer is mostly D. Again, why? We have acidosis here. It is not fully compensated. Why? Because we have a abnormal pH, not normal. If fully compensated, you will find this normal and the other changes is changed. The other values are changed, but this will be normal, but this is not normal. So it is a partial compensation. Next step is looking at PaO2. It is normal. This one and this one. Bicarbonate is low, so it is metabolic cause of acidosis. Very nice.
Yes.
But the patient is making like this to compensate by the respiratory alkalosis by wash out of CO2. Then the answer is D. Very nice.
Thank you.
So the answer is D. Very nice. Again, don't forget, because we have many examples, I will open the mic for all of you. How is the patient? Is the patient is hypoxemic and then pH, PaCO2, HCO, bicarbonate, and base excess. Now I will show you very nice diagram. Okay, sorry. No sound, no sound. Okay, respiratory failure. Okay, no problem. We are together. Okay, sorry. We have respiratory. We have, when you have PaO2 less than 8 kilopascal hypoxemia, you have now what's called respiratory failure. Okay, we have two types, type 1 and type 2. How to know? Look at PaCO2. When this is normal or hypo, you have type 1 respiratory failure. Okay, normal or hypocarbia, then this type 1 respiratory failure. When this respiratory failure type 2 due to high PaCO2 hypercarbic, this is called respiratory failure type 2, and this is also known as respiratory acidosis. It is the same, respiratory acidosis. Yes, it is respiratory acidosis. Why? Because of retention of PaCO2. Again, I will do it again. When you have PaO2 less than 8 kilopascal, then you have what's called respiratory failure. The patient is really actually hypoxemic. How to know this is type 1 or type 2 respiratory failure? From PaCO2. If it's normal or hypo, then this is type 1 respiratory failure. If it's high, PaCO2 is high, this is type 2 respiratory failure, and also it is respiratory acidosis. Is it clear? Yeah, yes, Dr. Kumal. Now you are asking about pH. Okay, I will repeat again. pH. Leave pH now. I am telling you, type 1 respiratory failure, you have no problem in acid-base balance. You have just hypoxemia with normal or hypocarbia. That will never cause affection of the pH. Maybe alkalotic, okay, but it is not severe like type 2. Type 2 respiratory failure, you have like kyphoscoliotic patient. Deformity of the chest. The lung expansion is low, then the patient is in hypoventilation. The CO2 will be high, and the PaO2, because of delivery of oxygen, will be low, less than 8 pascal. Then the patient is respiratory failure type 2. It is the same as respiratory acidosis. Respiratory failure type 2, it is actually respiratory acidosis because of hypercarbia. Okay, don't complicate it. Let's see examples. Okay, let's see examples. Okay, this case scenarios are not easy. Okay, so please try to concentrate. Okay, anyone raising hand? Dr. Ahmad Abaziz.
Okay. 60-year-old man with amyotrophic lateral sclerosis is brought into clinic by his family, who are connected that the concerned and disappeared.
Okay, now. Yes, now, please. Yes, now.
This one. Okay, a 24-year-old woman is found down in a Pioneer Square by some bystanders. The medics are called out. Upon arrival, find her with an oxygen saturation of 88 on room air and pinpoint pupil on examination. She is brought into the Harbor View ER, where a room air arterial blood gas is performed and reveals pH 7.25. In the acidic pH, in the acidic, BCO2 60. The 60 or 6.
Okay.
BO2 65. HCO3 26.
Okay, as we
Yes,
said,
excess.
this is 7.5 to 7.
This is the acidic side.
PaCO2 from 35, 45 millimeter mercury. EaO2 70 to
60.
100.
Yes,
And HCO3 22
26.
Okay. So what is the acid base state?
The BCO2 is elevated.
First, how is the patient? Pinpoint pupil, so the patient is not alert. Pinpoint pupil. Okay. Then oxygen
Hypoventilation.
saturation, then hypoxemic. No, not hypoventilation. Don't look at CO2 now. Look at how the patient. The patient is dying. Okay, pinpoint pupil. And is the patient is hypoxemic? Yes, it is less than
Yes.
40, 93 or 94. So it is 88%. Okay, so the saturation is very bad. The patient is hypoxemic. Then go to pH now. pH, is it normal? No. Is it acidosis
no.
or alkalosis?
Yeah, acidosis.
It very nice. So it is acidosis. PaCO2, is it normal or above?
No, it's above.
So it is respiratory cause of acidosis because of
Respiratory.
retention of this acid. Okay.
No, this is, yes.
PaO2, is that normal or not?
No.
The patient is hypoxemic, low. Okay.
Respiratory failure.
This one is normal. It is respiratory acidosis and also known as respiratory failure because you have low oxygen saturation. Okay.
Yes.
Again, the first question: the patient has low pH, so acidosis. PaCO2 is high. This is respiratory cause of acidosis. The anion gap is 10. How they calculate the anion gap? This is normal anion gap 10 to 20. How? I don't think they given the sodium. What the,
Sodium minus chloride plus
sodium
HCO3.
minus the negative charges, which are chloride and HCO3. It is not given. It is, we said 10 to 20, with or without potassium. It will be very clear. So it is acute uncompensated respiratory acidosis leads to acidemia.
Acidemia.
Thank you. Very nice.
Thanks.
Okay, thank you. Next one. Next one, Dr. Michael Medhat. Dr. Michael Medhat. Dr. Michael Medhat. Dr. Michael Medhat. Okay, no problem. Dr. iPad von Mustafa. Dr. iPad von Mustafa.
Yes.
Yes. Okay, go on. Case 2.
Yes. Case 2, 60-year-old man with amyotrophic lateral sclerosis brought into clinic by his family who are concerned that he is more somnolent than normal. On further history, they report they are has been having problems with morning headache and does not feel very refreshed when he wakes up. An arterial blood gas is performed and reveals pH 7.37, PCO2 57 PO2 70 HCO3 23.
Let's
Okay,
do. Is that normal?
pH normal.
Yes. Very
Okay.
nice.
PCO2 the normal range. Yes, high. Okay.
So you have high PCO2 and
Yes.
normal pH. How? Yes, fully compensated pH. How? What is the cause of compensation? This is. But
Yes.
look at pH. Is it near 35 or
Yeah.
near?
Near acidosis. Yes.
Listen to me, please. Okay, doctor. You have normal range. Yes. But is this near the acidotic side or near the alkalotic side? Near the
Near.
acidosis. So the respiratory acidosis compensated fully by metabolic alkalosis. Why
Yes.
fully compensation?
Because pH is normal.
Yeah, excellent, 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 excellent. So you have normal pH,
Okay.
but it is near the acidotic side. And the cause of acidosis will be the high PaCO2, not the high HCO3. So it is respiratory acidosis fully compensated by this
Metabolic
compensation.
alkalosis. Okay.
You are excellent, doctor.
Thank you very much.
Thank you. By time, you will never, even in your hospital, by the way, you will never stop thinking. Okay. So the patient has low pH, wrong one. The patient has normal pH. You trust now yourself. The patient, it is respiratory acidosis, yes. And summary, it is a chronic respiratory acidosis that is fully compensated by metabolic acidosis. Explanation, the patient has respiratory acidosis with compensatory metabolic alkalosis. Okay, the patient is hypoventilating while the compensation tell us that the chronic process by the renal compensation. This is amyotrophic lateral sclerosis, neurodegenerative disorder, so this will affect the respiratory function, leads to retention of what of PaCO2 and the chronic process of gain of the alkali HCO3 from the kidney will compensate for that. Again, lung and the kidney. Respiratory, metabolic. Lung stopped, CO2 is retained, pH is low because of CO2 is retained. Then the kidney within 48 hours with chronicity try to gain HCO3 to compensate for this retained acids by this retained what? Retained what? Alkali. Let's see in the mnemonic. The mnemonic is working or not. We have Rome, respiratory opposite, metabolic equal. This is respiratory. Yes. And so you have this opposite this. The pH is low and opposite the PaCO2 because it is respiratory is high. So it is working. It is opposite each other's. Okay. Very nice. Anyone has any question, tell me, because I'm ready to answer anyone, because acid-base balance is very easy and you will find no problem at all. Okay, next one, Doctor. Thank you, Doctor. You are excellent.
Thank you very much.
Thank you. Dr. Michael Medhat, are you ready?
Hello.
Yes, Dr. Michael, go on.
Hi, doctor. A 65-year-old man is brought into VA hospital with complaint of severe nausea and weakness. He has ulcer disease. In the past, he has been having a similar for the past 2 weeks. Rather than see a physician about, he opted to deal with problem on his own. And over the past week, he has been drinking significant quantities of milk and consuming large quantities calcium carbonate. On his initial laboratory, he found calcium level 11.5 milligram per deciliter, create 1.4, bicarb 30. A resident working in the ER decided to draw a room ABG, reveal pH 7.45, PCO2 49, O2 68, bicarb 34 in chemistry panel, the sodium 139, chloride 895, bicarb 34. الكيس of the patient ممكن peptic ulcer. بالنسبة للأوتو saturation ال pH في النورمال رينج، يبقى ده كده fully compensated. ال CO2 high، البايكارب high، ممكن metabolic alkalosis fully compensated.
So it is alkalosis and the cause is metabolic.
Metabolic alkalosis and pH near to the alkalosis.
Compensated by what?
Respiratory acidosis.
Excellent, excellent, excellent. So the patient has high pH, so it is alkalosis. Then the cause of alkalosis should be either loss of acid or gain of HCO3, which is base. So the HCO3 is high. So now you have metabolic cause of HCO3 is high. This will explain this alkalemia or alkalosis. So HCO3 is metabolic and it is high, causing alkalosis. Look at pH, it is normal. It is 45, 745, so it is normal. Why? Because the CO2 is retained, the acid retained to compensate for this alkalosis. Summary, this is a primary metabolic alkalosis fully compensated by respiratory compensation. What is the explanation? The patient has hypercalcemia and the metabolic alkalosis in conjunction with a clinical history of heavy milk and calcium consumption suggests the patient suffering milk alkali syndrome. This milk alkali syndrome leads to alkalosis, develops hypoventilation to compensate by retention of some acids because this alkalosis. Very nice. And also this will explain hypoxemia.
Thank you, doctor.
Thank you. Excellent, doctor. Okay, very nice.
Thanks.
Thank you, doctor. Dr. Muhammad Ahmed. دكتور محمد أحمد يلا. دكتور محمد أحمد. Okay. دكتور ايباد فون مصطفى. دكتور محمود عاشور again.
حضرتك سامعني؟
السلام ورحمة الله وبركاته. دكتور عبد الرحيم، دكتور أحمد، دكتور أحمد عبد العزيز. Anyone can participate with us. دكتور جراف، دكتور عبد الرحيم، دكتور عبد الرحمن حسن. Okay, anyone, please participate with me. I'm not. I feel alone. I feel I'm alone. Okay.
دكتور رضا حضرتك سامعني؟
Yes, Dr. Muhammad. Go on. يلا.
Okay, this is a 45-year-old woman with a history of inhalant abuse presents to the emergency room, complaining of dyspnea. She has an SpO2 of 99% on room air and obviously tachypneic on exam. What appears to be cosmorespirations, room air arterial blood gas is performed and reveals pH of 6.9, PCO2 9, PO2 128, HCO3 2, A chemistry panel revealed sodium of 130, chloride 98, HCO3 of 2. So pH is 6.9. This is acidosis. Bicarbonate is 2. Bicarbonate is 2. This is a metabolic alkalosis.
How
Partial
metabolic
compensated
alkalosis
metabolic
ازاي
alkalosis.
ازاي ده mixed acidosis. انت
Sorry,
عندك
sorry. لا, sorry. This is acidosis from the first. This is acidosis, okay. Mixed acidosis. I'm sorry.
yes, you have two
BCO2
causes of
low.
acidosis here. You have what is called mixed acidosis from, again, I will explain again. Thank you, doctor.
Yes,
I will tell you how is the patient. You have to be
Mixed
excellent in
acidosis, right.
internal medicine as general surgeon. Yes. Why? Because before you will be given, you know that the patient is tachypnic. So he trying to wash out this amount of acid, okay, because of this abuse of inhalant. What is inhalant? I don't know, but it's a substance cause metabolic acidosis and also respiratory acidosis, leads to mixed respiratory
yes.
metabolic acidosis. Okay, so the patient
Yes.
is acidic, low P respiratory sorry، ايه ده؟ دي respiratory، لا دي غلط كده، دي explanation غلط.
ما انا بقول لك ما بقول لحضرتك ال CO2 is 9 which is low.
هو مش 4.5 مش 4.5.
Bicarb is 2.
ال PaCO2 4.5 ل 6 4.5 to 6
by kilopascal.
Okay, but it's not given kilopascal or not. Not kilopascal, not given kilopascal. If it's kilopascal, it is high, but it's millimeter mercury is
Yes.
very, yeah. Okay, very nice.
If it's by millimeter mercury, it will be low.
So you mean that this is millimeter mercury, which is 35 to 45.
Yeah, I think so.
Gone
Yes.
to this. So it is lost by tachypnea. Okay, so you have respiratory alkalosis, and this one is metabolic acidosis, yes, compensated by respiratory alkalosis. Okay, I thought it is a mixed scenario. Yeah. Okay, now this is not kilopascal.
Yeah, so
this is millimeter mercury. Excellent. Again, the patient have low pH, so acidosis. The PaCO2 in millimeter mercury. Thank you. Low PaCO2 and very low bicarbonate. This is metabolic cause of acidosis, this pH. So the PaCO2 here in millimeter mercury lost by tachypnea. Let's see the explanation. Okay, explanation of the case. The patient has concurrent elevated anion gap and non-GANAB acidosis with respiratory compensation. The acidosis are so patient have history of inhalant abuse, and the commonly abused inhalants toluene can present with severe elevated anion gap acidosis. Isoniazide, it is like mud biles, HAGMA or high anion gap metabolic acidosis, toluene, sepsis. Let's keep this mnemonic in the beginning of the lecture again. High anion gap metabolic acidosis, mud biles, and normal anion gap metabolic acidosis are hard ups. Okay, excellent. Yes, I need people participate with me. Dr. Gurav, welcome. Thank you, doctor. You are excellent, Dr. Muhammad.
No, doctor, can you hear me?
Yeah, I can hear you clearly, very clearly.
A 68-year-old
Thank you.
with a history of very severe COPD. This looks more towards respiratory chronic carbon dioxide retention. presents to the emergency room complaining with worsening dyspnea and an increase in the frequency and purulence of his sputum production over the past 2 days. His oxygen saturation is 78%, which is less. So respiratory problems. Before he is placed on supplemental oxygen, room air arterial blood test is drawn, which reveals pH 7.25, which is less, that means acid, PCO2 of 68 millimeter mercury, or in that case it is high, which means acid. PO2 is 48, which is less, again acid. Bicarb is 31, which is more. So pH is not normal. This is respiratory acidosis with partial compensation by metabolic alkalosis.
Yes, this is a chronic respiratory acidosis of chronic obstructive pulmonary disease, COPD. Okay, so here, summary: primary metabolic respiratory acidosis, metabolic alkalosis. The explanation of the case: the patient is very severe COPD and chronic carbon dioxide retention. As a result, you expect that the baseline chronic respiratory acidosis with a compensatory metabolic alkalosis. Very nice question and asked many times in many exams. The COPD patient will be respiratory acidosis compensated partially by gain of the alkali, which is HCO3. Very nice, Dr. Gurav. Thank you. You are excellent. Dr. Ahmed
Thank you, Dr.
Abaziz.
Rida.
Thank you. Excellent, Prof. دكتور احمد عبد العزيز باشا، اتفضل يا باشا.
Here, a climber is coming down from the summit of Mountain Everest at an altitude of 7,400 meters. He has a blood gas drawn while breathing ambient air as part of a research project. The blood gas reveals pH 7.25, PCO2 12 millimeter mercury, millimeter mercury or kilo pascal.
لا، ما هي دي خلاص مليمتر ميركوري. مليمتر ميركوري.
millimeter mercury. So it's low.
هو كده ماشي مليمتر ميركوري.
Yes, it's low. PCO2 30, PCO2 12.
Yes.
And PO2 30. So,
ترجمها. انت عندك البي
Hypokalemia.
اتش is that normal؟ خلاص
No,
تعالى نترجمها واحده واحده.
alkaline alkalosis.
ثواني كده. اوكي، يلا ترجمها لي واحده واحده. انت عندك بي اتش دي نورمال ولا لا؟
لا abnormal. It's an
انت
alkalosis.
عندك الكالوزس. الكالوزس مين هيكون فيه السبب فيه؟ يا اما السي او 2 لوست، يا اما مين؟ يا اما الالكالوزس عالي، الاتش سي او 3 عالي. اوكي، is that correct? So the alkalosis cause is that one?
No, it's
not
loss
it is not high. But this one, it is in millimeter mercury. PaCO2 is lost. Loss of acid cause alkalosis. So it is respiratory.
Respiratory alkalosis.
So it is a hyperventilatory state.
Due to high altitude.
But it is compensated or not? Is that normal?
Yes,
compensated by the renal loss of
carbon
dioxide. So it is what at the end? It is what?
Respiratory alkalosis.
Yes.
Compensated by metabolic acidosis.
Excellent.
Respiratory alkalosis.
Yes. So the patient has alkalosis. PaCO2 is low. It is respiratory alkalosis. Summary: this is primary respiratory alkalosis with compensation, metabolic compensation. Explanation: the patient is climbing at extreme high altitude where very low oxygen tensions are in arterial. So by hypoxemia, hypoxemic ventilatory response make a hyperventilatory state in high altitude leads to loss of what? Loss of PaCO2 causing metabolic alkalosis. Thank you. Excellent.
Thank you, sir.
Okay, next one. دكتور عبد الرحيم. طيب دكتور محمد فتحي. السلام عليكم.
عليكم السلام ورحمة الله. A 57 years old woman presents with 2 days of fever, dyspnea, and cough. Productive of rust-colored sputum. Her room air oxygen saturation in the emergency room is found to be 85%. And the internal doctor to obtain a room air arterial blood gas while they are waiting for the chest X-ray to be done. The blood gas revealed pH 7.54, BCO2 25, BO2 65, HCO3 22, base excess سلب واحد. She is the pH is she has alkalosis. The BCO2 is low. The BO2 is
لا خليك ثواني خليك ما تمشيش. ده alkalosis. Don't go. This is alkalosis and this is low. So it is respiratory or respiratory or metabolic?
Respiratory.
Yes, because this is respiratory loss of PaCO2. So it is respiralkalosis. Okay. So then go to PaO2. It's not important.
It's not important. HCO3 normal.
No, not normal. هي normal.
Slightly.
But base excess will reveal more than the pH3. So depend on base excess more than
base excess from 2 to -2. يعني this is normal.
No يا راجل لا. this is normal يعني. طب استنى. صح نورمال. ما انت عندك من -2 لزائد this is normal.
يبقى دي هي سمبل بقى
واحد كده. يبقى this is normal. So it is isolated respiratory alkalosis.
Not isolated respiratory alkalosis يعني acute.
Fever, hyperventilation. So summary: acute uncompensated respiratory alkalosis. Excellent. Yes. You are better than the persons that discuss with you. You are excellent.
Thank you.
Thank you. Excellent. يلا انا مش عارف عمال اتلخبط ليه. يلا.
You are the best.
الله يكرمك. تسلم. دكتور احمد عبد العزيز. خلاص يعني انتوا فهمتوا الاسيد بيز يعني خلاص ما حدش عايز يرفع ايده. وخلاص الحمد لله. بصوا كل دي اسئله سهله جدا في الاسيد بيز. تعالوا ناخد سؤالين مثلا. دكتور احمد عبد العزيز.
Yes, sir. A student is nervous for a big exam and is breathing rapidly. What do you expect out of the following? Breathing rapidly, so he is in hyperventilation state. So PCO2 will be low. This means alkalosis, respiratory alkalosis.
Very nice. Excellent. اللي بعده. Uremia.
Me also.
Yes, you also.
A 45-year-old female with renal failure missed her dialysis and was feeling sick. What could be the reason? Renal failure. Yes. High anion gap. Metabolic acidosis.
Yes.
Metabolic acidosis.
Yes. Next.
I'm feeling tight. An 80-year-old man had a bad cold. After 2 weeks, he said, I went into my chest. I am feeling tightness in my chest. I am coughing, suffocated, and unable to breathe. What could be the possible reason? Unable to breathe, there is tightness. So, yeah. There will be retention in CO2, so he will suffer respiratory acidosis. Respiratory acidosis.
طب يلا كمل.
Which of the following laboratory results below indicates compensated metabolic alkalosis? Compensated metabolic alkalosis. Compensated.
Sorry.
Yes. Okay.
مش راضي يتم. طب كمل، انا ما شخبطتش ايوه كمل.
Okay, metabolic alkalosis. So the HCO3 will be above 26.
Compensated BVET. So it is alkalosis. So BH should be
maybe partial or.
So this one is wrong, B is wrong, and C is wrong. So you have now A and D.
A and D, yes, A and D. High bicarb, so it will be D.
D, are you sure? Yes, metabolic alkalosis by hypercarbonate by pH. Yes, excellent. Because we said if you know it is excellent, but if do this mnemonic, it is metabolic alkalosis. Metabolic this equal to the alkalosis. So pH is high. So with metabolic cause, so high also bicarbonate. So it is metabolic and high PSO2 to compensate. Very nice.
The greatest buffering capacity at
causes of metabolic alkalosis include all of the following.
Except metabolic alkalosis, mineralocorticoid deficiency. No mineralocorticoid it will cause metabolic alkalosis, hypokalemia, thiazide diuretics, current vomiting will cause, thiazide will cause hypokalemia. Mineralocorticoid deficiency will not be hyperaldosteronism.
Mineralocorticoid deficiency will cause what? Like aldosterone deficiency.
Yes.
It is correct. Why? Aldosterone leads to salt water retention and hypokalemia. But in deficiency now, salt water loss with hyperkalemia. Hyperkalemia will cause acidosis. Okay. Next one. Causes of lactic acidosis. Yeah, we have lactic acidosis type 1 and type 2.
Type 2 metformin.
Metformin, and type 1 is perfusion like sepsis, hypoxemia, like that. Okay, causes of lactic acidosis include of the following except infection, okay, circulatory failure, okay.
Hypoxia, okay. Acute mild, no.
But what is hypotension? Perfusion, yes. Let's check. Question number 14 is what? D. Question number 14 is D. So you have the answers. Infections, but infections, this is sepsis and cause type B also. I don't think this is correct because it causes infections. Yes, it causes lactic acidosis, septic. Okay, thank you. I have finished. Anyone has any question? Tell us. Thank you.